It's a pleasure coming from Frederick to get onto 70 West instead of 70 East, and to come out here to beautiful Western Maryland. We're going to talk about elimination disorders this morning, basically talking about enuresis and encopresis. Really the things that they have in common are that they're both related to toilets. But beyond that, there's really not a lot. They're really very, very separate disorders. And in fact, the issue is not related to toilets, it's related to not using the toilet or not using the toilet appropriately. And that's the commonality, but they're two separate orders. So we're going to handle them separately. We're going to talk first about enuresis. Enuresis is an extremely prevalent issue. It's basically a developmental issue. I put down some of my favorite numbers, but if you look in different places, you'll find great variability in the numbers. Nobody really knows exactly what the prevalence is or the incidence, and it really seems to vary from culture to culture, so that Sweden and England, who've done a lot of studies on prevalence, have pretty different numbers than we have. But basically what I keep in mind are some that are easy for me to remember. 25% of 5-year-olds still wet the bed, 7 to 10% of 7-year-olds, obviously inversely, 10% of 7, 7% of 10-year-olds. And that there's roughly a 15% spontaneous remission each year. So of any cohort of enuretics, about 15% of them will stop bedwetting in any given year. As with most developmental problems, it occurs in boys more than in girls. A lot of the names you'll see in literature as you watch this are PNE, which is primary nocturnal enuresis, SNE, secondary nocturnal enuresis, and MNE is the newest one, is monosymptomatic nocturnal enuresis. And essentially they're trying to get out this group of kids who really have only bedwetting, and that it's not a more complex either urologic problem or other related problem. There's a very strong genetic component, so that if two parents are bedwetters, probably 2/3 of their kids will have a problem with bedwetting. And that's a significant issue as well. So when I get a family in, I go through a lot of the things that Ken talked about, and the first thing I want to do is assess what the parental and child stress is relative to bedwetting. So I'd say probably 10 to 25% of the kids and families that I see, the parents come in, we ask about bedwetting, they say, oh yeah, he wets the bed probably 4 times a week. We have the mattress covered, and it's really not a big problem. We know he's going to outgrow it. We've had it in the family. The kids are pretty calm about it, and there's probably nothing you really need to do about bedwetting. On the other hand, I sometimes will see parents coming in where the families are extremely stressed. I can't do the extra wash, we're so busy, we have so much going on. His brother teases him about it, the room smells, you know, and they'll go on, and that the kids are really having a lot of problems in that it's interfering with lots and lots of issues for them. So they can't go to sleepovers, they're worried about going to friends' houses in the evening, and they're worried about having accidents. They're worried that people will find out that they're bedwetting. So the first thing we try to do is see what parents think and what their concerns are, and try to answer some of their questions and see what myths they're thinking about. I can't remember the last time I did an initial evaluation for bedwetting and didn't have a parent tell me he bedwets because he sleeps so soundly, if a fire truck ran through the room, he would not wake up. And, you know, kids sleep soundly. It's wonderful to be a kid. If you watch them sleep, you can't wake them up ever. How many times have you had your kid taking them from the car into the house, taking them from the house upstairs to their room? They never wake up. Kids sleep soundly. And when people have done sleep studies with kids with enuresis, there's really no clear correlation. There's some literature that looked at bedwetting as perhaps a dysomnia or a parasomnia. The support for that when they've done sleep EEG tracings is really not very good. So there's really not good evidence that these are that type of disorder. The other thing about sleep, that there's a literature that probably in the last 10 years there's been some increasing literature on the relationship between obstructive sleep apnea and enuresis, and not clear again exactly what that relationship is. That there are both components, they somehow seem to travel together, but there certainly is no sense that there's causality and that it's obstructive sleep apnea is the basic problem. The issues that parents and kids have is when are they going to grow out of it, when is it going to stop, and then of course are there things to do about it. So we try to demystify the process. It's not the problem that they had a liter, well, if they had a liter Coke after dinner, that may have been the problem. But the problem usually is not that they're drinking too much fluids. Fluid intake is not related to kids developing enuresis. One of the favorite things that parents do with kids is called, the English have a wonderful term for lifting. And lifting is when you wake a child up before you go to bed, you sort of take them into the bathroom and have them void and that they stay dry during the night. Now, I will tell you, my son lifts his daughter, that they take her into the bathroom, she urinates, and they go to bed, and that she's then dry through the night. Now, she's 3, so it's not an issue. And if this works, I don't have any problems with it. It really is not a good treatment for bedwetting. So when parents take this a step further, because the kids are continuing to bedwet, and they'll take it a step further by setting their alarm clock for 2 a.m. or 3 a.m., going and getting the kid, it really is pretty disruptive to a household, and it's not treating the bedwetting. Kids don't learn to be dry by being lifted at night. So generally, if I hear lifting is the issue, then I'll try to explain to the parents that it's not doing anything if it works to keep them dry and it works well into the schedule. Mom always watches Jay Leno, and after Leno she takes the kid to the bathroom, that there's not a problem with it. But again, should not be recommended as a primary intervention. And then the last thing, and I think probably the most important, is normalizing this behavior for children. Even when kids say they don't care, they care. It's an infantilizing behavior. Babies do this. If they're wearing a pull-up at night, it's a diaper, and that they really have feelings about it. So we can try to normalize the process for them. One of the things and I have some scripts on the handout that I had, and the script I typically use with kids is, Johnny, you're in 3rd grade. You know there are 2 or 3 kids in your class who wet the bed. And again, if we go that 10%, 30-room classroom, 30-kid classroom, 3 is probably a good average. There are 3 kids, and then the kids always go, yeah, who? So, you know, I don't know, and they don't want to talk about it, and you don't want to talk about it because it's private and personal. But generally, most 3rd grade classes have 2 to 3 kids who wet the bed. Again, as you're taking a history and getting a family history, hearing from families that, yeah, Dad wet the bed, Uncle Jack wet the bed, 2 cousins wet the bed, including that information and reinforcing that for the kid, you know, that's pretty typical. Bedwetting often runs in families, and that people grow out of it, but that's a problem when kids are your age and may have some difficulty wetting the bed. As opposed to more serious emotional problems, oftentimes when kids are in for enuresis evaluations, that it's just the mother who brings them in. And I'll ask the mother if there's any bedwetting in the family. She said, nope, nobody in my family. And I said, how about your husband? She said, well, I don't know. And I guess it's, not pick-up conversation. Hi, I'm John. I wet the bed till I was 8. It doesn't come up. And many times parents will come back and say, I asked them, he wet the bed. And they just don't know about it. So that's sometimes history you have to work a little harder to obtain. I didn't go through the medical evaluation of enuresis. Obviously, anything that increases urine output, glycosuria probably being the most significant and important, will increase bedwetting. Anything that decreases bladder capacity, so a spastic bladder that can't hold as much urine, will be a problem. Anything pushing on the bladder, the most common thing that pushes on the bladder is stool. We'll get into that when we talk about encopresis. But that will have an effect on kids not being able to stay dry at night. External mass, so that obviously a history and good history, good physical exam is part of this evaluation. This is a medical problem. People are coming to you as a physician, and a lot of the strength of what we do is as a physician, and we should use that and use that information. I do urinalysis on all the kids. I can't remember when I found a urinalysis helpful in my bedwetting diagnosis. Obviously looking for concentrating ability, depending how much you can interpret that. Obviously, if it's a concentrated urine, you can know that the kid concentrates and they don't have diabetes insipidus. And I look for any signs of urinary irritation, blood, pyuria. I typically will send out a urine culture at least once on kids with urinary tract infection. And clearly, part of that medical history is anything that irritates the bladder may cause bedwetting, and urinary tract infection being the #1 issue. So once we've diagnosed it and come up with the idea that this is a primary nocturnal enuresis, it's not complicated, there are not a lot of other medical problems, what can we do with it? And basically there are 4 or 5 basic interventions that are helpful in bedwetting. Motivational interviewing, motivational counseling, working with a youngster, doing star charts probably does help, although the help is probably fairly minimal. If you look at that 15% a year baseline, for younger kids probably adds another 10%. So that kids who are wetting every night, it probably doesn't help. But kids who are having wetting 3 or 4 nights a week, to talk about staying dry at night, to use a positive reinforcement system, a star chart, and giving them rewards for being able to be dry is a reasonable thing to try, probably with the 5 and 6-year-olds if parents are interested and want to do that. An extension of, this is funny because it's actually 2 ends of a spectrum. So motivational star charts is the pretty easy end and accessible to most of us. At the other end is a psychological intervention called dry bed training, where a psychologist moves into the house with the family and stays at night, and they do a whole bunch of training of getting the kids up and doing practicing and going to the bathroom and a whole bunch of things. And it's a very effective intervention. If anyone's interested, I can give you references if you want to go to your kids' houses and wake them at night to go to the bathroom. But I don't think it's an accessible intervention for pediatricians, and certainly not a brief one. The bedwetting alarms really should be the mainstay of our treatment for enuresis. They work, they're excellent. There are estimates of anywhere from 60 to 80% success rate with bedwetting alarms. The recidivism with them is low. Probably only 15% of kids who've been treated successfully with an alarm system go back to wetting. The problem with it, kids hate it. They really don't like it, and what you really need to do with alarm systems, if you're working with them, is see the kids a lot of the time, work with them how well they're doing, work with them on the alarm. When I present enuresis to kids, one of the things I present is that this is hard work. This is hard to do. I do the same thing with encaprices. So we're dealing with latency-aged kids. And what do latency-aged kids do? They're industrious. They want to do things. They want to get things done. It was 100 degrees outside. We were walking around town. There were 4 lemonade stands that we passed, getting early in the season. That kids really have this motivation to do things. So you present them, this is a hard job. This is hard to do. And that they often will rise to that challenge. And be able to be more involved and more invested in the system. But they don't like it. It wakes them, and I'll go through bedwetting specifically in the next couple of slides. Hypnotherapy is effective. If you have a hypnotherapist in your community who works with kids, it is a pretty effective intervention. Bladder stretching exercises, when we do urologic studies on kids with enuresis, they have normal urinary systems and normal bladders. Having said that, functionally they seem to have a small bladder capacity. It's not 100% clear what that means, but that functional bladder capacity seems diminished. And what people have done is had kids try to hold urine. So they pee in a cup, hold urine for as long as you can, pee in a cup, measure the volume, and see if you can hold it longer to increase and stretch the bladder. Some recent articles suggest that this is not very effective, and even not very effective adjunctively when you do it with other things. And then the last thing is pharmacotherapy, and pharmacotherapy is also effective, and we'll talk about the agents in a couple of minutes. So this is my protocol for kids using the enuresis alarms. I'll tell you about some alarms at the end of the enuresis section. Again, drinking too much is not the reason kids wet the bed. So that some parents really get punitive with it. No, you can't drink, you're going to wet the bed. And the kids are, it's 100 degrees, I was outside. No, you can't have anything to drink. So reasonable fluids is fine. Obviously, if you're trying to stay dry, you don't do a liter of Coke or a 6-pack. That's counter, obviously too much fluid is going to put you at risk. You're trying to achieve dryness, but reasonable fluid should be fine. Make sure the kid always goes to the bathroom before bed. That's a duh, but a lot of times when you reinforce that with the kids, it's not happening. And through the evaluation, what I keep on telling kids is the goal, what we're working at, is waking up in a nice, warm, dry bed. And I repeat that probably 4 times. And when I go through the protocol, I close my eyes and I say, when you go to bed, think how nice it's going to be to wake up in a warm, dry bed. So am I hypnotizing them? I don't know. But suggestion is powerful in kids, and to work with suggestion and use it to my advantage, I throw it in there. Why not? And it's giving kids one more thing sort of to think about. And with a lot of these things, and when you have a protocol and you have something to do and you add that structure, it's very, very helpful to the kids and parents, and it's very helpful to helping achieve the goal. Then the last part is using an enuresis alarm. I think most 8-year-olds cannot and should not be held responsible for getting up and taking care of things when the alarm goes off. They really need parental support. So this is, we're dealing mostly with school-age children, and I think that the idea that the kids should be responsible for this is an erroneous idea, and that parents have to get up and do this with children. And if parents say, I don't hear the alarm, they need to have a monitor in the room, and the monitor goes off in their room as well, and they have to come in. And they have to wake the child up and say, your alarm went off, it's time to go to the bathroom. In the handout, I have a script that, again, I use with families and children, and how I present the idea of alarm and alarm training. Basically, it's not a punitive system, but a teaching system. I'd like to wake you up before you wet the bed. I don't have a good way of doing that, so I do the next best thing and wake you up right as you start voiding, so that you can learn to get up and go to the bathroom. So the alarm goes off, and the kids go up and they go to the bathroom and they finish urinating. That the goal is to wake up at a warm, dry bed. You get into dry, you change the sheets if they're wet. You get into dry underwear, dry pajamas. Actually, the alarm often stops the voiding so that everything doesn't get wet, and that you don't have a lot to do. Again, this shouldn't be punitive. We don't need hospital corners in the beds. Throw a new sheet on, get the kids back to bed. But before they do, they have to practice going to the bathroom. And this is part of the dry bed training, so that we're learning a new skill. How do we learn something new? As we practice it, and they have to practice a couple of times. Don't let them go back to sleep while they're awake. Just go back to the bathroom, pull down your drawers, make believe you're going. Obviously, they're not going to go at that point, but that they practice twice before going back to bed, and then they track progress on a calendar. That frequent follow-ups on this are essential. We should be seeing the kids probably at least every several weeks to every month to reinforce the system and to work with them. One of the problems is they don't like getting up. As the system goes, number one, they're not having fully wet beds, and they can see that progress. Number two is the alarm's not going off as frequently. So if you can get them to bear with it the first month or so, they're off you get a good start, and they're on their way to some progress. The pharmacotherapy of enuresis, 2 medications. DDAVP, desmopressin, is a synthetic vasopressin analog. It used to be only available as a nasal spray, and kids didn't like the spray. They've made it a tablet. The tablet is 100 times, I think, the strength of the nasal spray. Nasal spray was it's a protein and was absorbed immediately. The tablets obviously get partially digested, so they give you a similar blood level. They're 0.1 and 0.2 milligram tablets. People start at 0.2, and you can titrate up to 3 tablets at bedtime safely. Desmopressin is probably about 75% effective in stopping bedwetting. That when you stop desmopressin, probably 50% of the kids will start wetting again. So that the recidivism is very, very high. Some kids will use medications when they're going away. They're going to a friend's house. They'll use they'll have an established dose, and they'll take it then and not worry about it when they're home. I put imipramine on because it's been a classic treatment for bedwetting for at least 40 years that I know of. I don't use imipramine. The therapeutic window on imipramine is very small. When people were using a lot of imipramine, it was the #1 poison, and it has a really it's a horrible poison to deal with. It works at very low doses in bedwetting, and it's not its antidepressant effects that are the success in bedwetting. Nobody knows exactly where that comes from. I went on the web and Googled bedwetting, and this is the first 7 that I found, and the page, it went on and on and on. Dry buddy, no bedwetting, sleeping dry bed, just numerous things. Why is that? 25% of kids bedwet, and there's money in it. And it's money that, first of all, it shouldn't be going out of pediatric offices, but that's not the issue. Some parents will come in and tell you, they went on their own and they found something for bedwetting, and they paid $800 to get a bedwetting alarm, essentially. That there's some bells and whistles and support with it. But there's a tremendous amount of stuff available at bedwetting. The one down wet stop alarm is the one I usually use. It's one I've had, Palco Labs. I've had a lot of success with it. There are lots of night-tone, there are a lot of alarms out there. They're all good. The problems, if you're old and heard about alarms 50 years ago, they used to have shocks, they used to have bad electrical pads, and they shock kids. They don't do any of that anymore. They really are, they're miniaturized, they're pretty easy to use. Some of them vibrate, all of them make some sound to wake the kids up. So you can look online and find anything about alarms, or have your parents pick an alarm and come back and you can set up a protocol with them to work the alarm systems. So that's it on enuresis. We're going to go into encopresis for the last several minutes, and I'm going to do something that's against my better judgment. I told people I was doing this and they encouraged me, so I'm going to go ahead and do it. The trouble is he's lazy. The trouble is he drinks. The trouble is he's crazy. The trouble is he stinks. The trouble is he's growing. The trouble is he's grown. Krupke, we've got troubles of our own. So my apologies to Stephen Sondheim. Thank you, Barbara. This was obviously written about juvenile delinquents. This is the Sergeant Krupke song from West Side Story. It struck me how much this applies to kids who are encopretic. So the issue is the soiling, but the issue mostly is the psychological and associations that parents and children have with soiling. So that the only one that people don't come in saying they think it's the reason their kids soil is that he drinks. But lazy all the time. He doesn't want to go to the bathroom. He won't take time to go to the bathroom. He's too busy doing his Xbox, and he has an accident. Crazy comes up often, and that's what they hear from parents. Stinks obviously has its own implications. That he's too young, he's too old, he hasn't been toileted right, are all the things that go on with encopresis. So encopresis is a problem because of the associations with encopresis. It's really, the prevalence is not clear, but it's estimated probably about 1 to 2% of school-age kids. Again, typically boys more than girls. And it's questionable, but there's a strong school of thought that think there are a genetic component to encopresis. And perhaps it's irritable bowel syndrome as a common factor. But a lot of times, there's certainly a cohort of kids who come in, and when you hear from take the history that the dad had problems with either functional constipation or encopresis when he was younger. The big issue with encopresis is the psychological problems. When I was an intern, and there's somebody in here who knows when I was an intern, because she was an intern at the same time, that when we went into the emergency room and rotated through, the common wisdom was kids with encopretics have serious emotional problems and they needed an immediate referral to child psychiatry. So the pediatric management of encopresis was a referral to the child psychiatry clinic. And if you look at them, and you take histories and you do Ken's analysis, they have a lot of problems. That there are lots of things related to being a soiler. Enter Mel Levine. This was in the 70s, and he based his work with some other people and started treating encopretics for their functional constipation. And lo and behold, what did they find? The psychological problems went away. So it's not clear if they have psychological problems that cause them to be encopretics, which certainly is true for a group of youngsters, or if they have psychological problems because they're encopretic. That they're worried about soiling, they're worried about what kids say, they withdraw, they get teased, whatever the other, they get bullied, whatever the other factors are. Mel came up with a treatment protocol that's essentially the same one that I use today, and I'll go through that with you. But it really was a wonderful light going on for pediatrics to give us an insight into what's a medical pediatric problem. The issue then is parents come in having all these thoughts about why the kids soil. Kids come in and have all these thoughts about why they soil. And basically, they don't know why. So they listen to what everyone told them. They're lazy? That must be it. I must be lazy. Other kids pay more attention. I don't pay enough attention to going to the bathroom. That crazy, I think some kids think, it's an inherent personality defect that they can't keep clean. So the first step to work with families and children is a demystification process. And I do the same thing that Mel described in 1976. And on the paper I was looking, there's no blackboard or flip chart here, but I do colon drawings with them. So we said, get off the table, I'm going to draw. And we do a picture of a normal colon, looks like a donut. And we do a line across it and we said if we look at this under the microscope, we'd see very tightly packed muscle cells and nerve cells, and those muscle cells work by communicating to each other because they're close to one another, and the nerve cells know what's going on because they're close and in the mix. And then we draw a picture of a stretched out colon, and essentially it's a big thin O. And that's the weak muscle of kids with encopresis. And that muscle's not strong enough to push all the poop out of the colon. And the cells are all disconnected, and they can't work together, and they can't be strong, and they can't have a strong push to get the poop out. And the nerve cells don't know what's going on. And the kids then don't smell the fact that they're soiling, and they don't feel the need to defecate. So when you ask kids why they soil, they say, I don't know, I have to go until I start going. And it's not till the stool's coming out of the external sphincter that they're really aware that they're defecating. They don't have any defecation urge. So this vicious cycle develops, and we see the problem of encopresis. For lots of kids and lots of parents, you sit there and they say, can I take that paper home with me? It really has meaning for them because it gives them, it doesn't have to be that I'm crazy. It doesn't have to be that I'm lazy. There's some medical components to doing it. Again, we elicit hard work, and we get them to move on. The script I use for encopretic kids is we talk about muscle training, and they all understand strengthening muscles. They said, oh yeah, you can lift weights. And we said, well, we can't send your bowel muscle to the gym to lift weights, although what we want to do is strengthen that muscle. So we do other muscle strengthening exercises. And again, the muscles and muscle strengthening is an analogy that kids really can accept and understand. And we do a bowel training program. Essentially, bowel training is getting the kids clean, getting all the excess stool out of the bowel. What I used to use was the protocol with mineral oil and laxatives and enemas, God forbid, and we put kids through this rotation of cleansing and then training. Miralax is wonderful, and it has an A in it after the R. Miralax comes up on spell check, even in medical spell checks, as misspelled when you spell it right. So it comes up misspelled, and I didn't look that I spelled it wrong. It's Miralax. It's now available over the counter. It's polyethylene glycol. It brings fluid into the bowel. It's an excellent stool softener. It's used for cleansing and clean outs for people who are getting bowel studies, and it works great on kids. It's tasteless. The cap is a huge cap. Around the middle of the cap there's a white area. That's a capful. A capful in 8 ounces of water daily for most kids is an appropriate starting dose. You don't want them runny, and you want them soft, and you want them going on a regular basis. I put them on a high fiber diet because I think fiber is wonderful for the bowel and helps with regulation. I instruct them to sit on the toilet twice a day after breakfast and after dinner, trying to get the natural gastrocolic reflex working. That should be fun time. It's not punishment. That you can take your iPad in with you, you can take a book in with you, but you're trying to have a bowel movement. So a lot of times the kids will come in, they sit on the toilet, they're playing their iPad, and they go out and they didn't have a bowel movement. So you have to really remind them they're there for a purpose, and they're there to try to have a bowel movement. And then we try to track their success on a calendar, and I gave you a little cartoon in the handout on how I do that. Essentially, I have them put checks when they sit. I have them put X's when they're having bowel movements, and I have a star or a sticker being the main part of the calendar looking for clean days, because ultimately clean days are the goal. Again, I think frequent follow-ups are important. You really have to keep kids motivated with doing this. You have to maintain a bowel training program for at least 3 and probably 6 months in most kids, and you have to keep them motivated to keep going because they will easily regress, start accumulating stool, and stretch the bowel right out again and have problems. Overall, people have gauged about a 75% long-time success rate. So there have been some recent studies that have looked at encopresis over very long follow-ups. About a quarter of them continue into adulthood with probably not encopresis, but significant functional constipation. Consider referral if there's a history that there's a more need for a more comprehensive team. Encopretic is this very, very large spectrum disease. Some kids are encopretic because they had an anal fissure when they were 3. They withheld stool. They couldn't go. The more they withheld, the larger the stool got. The larger the stool got, the more it hurt to go. They started leaking around the stool, and they just don't want to go to the bathroom. Some kids are encopretic because they're sexually abused and that there's a lot of trauma and emotional issues associated with the genital area, and that they soil for that reason. Obviously, those are two different kids. Linda and I were talking about our training a minute ago. Dick Sarles always told a story about encopresis, where there was a youngster who mom had one of those chenille bedspreads that had concentric circles on it, and the kid would always have his bowel movement in the center circle. That's different than a kid who's just constipated. So there are obviously other issues going on there. So if there's more significant psychological issues, early resistance to noncompliance, or need for a more comprehensive team, it's time to refer to one of the tertiary centers. And that's it.